This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Neurosurgical Review, published in 2026, titled Evaluation of Functional, Structural, and Electrophysiological Optic Nerve Changes Following Extradural Anterior Clinoidectomy in Patients Without Preoperative Optic Canal Compression.
This is a topic close to my heart, Alara. We often talk about the anterior clinoidectomy in the context of large tumors or complex periclinoid aneurysms, where the nerve is already under duress. But this study addresses a very specific and perhaps overlooked question. What are we doing to a healthy optic nerve when we perform an extradural anterior clinoidectomy, or EAC, for purely surgical access?
Exactly. The authors point out that while the technique was pioneered by Hauser and Gass back in 1952 and later popularized by surgeons like Hakuba and Dolans, its role has shifted. Originally, it was for decompression of the nerve. Now we use it to gain proximal vascular control or to improve exposure of the opticocarotid and chiasmatic cisterns.
Right. In this specific series, the researchers performed EAC in cases of ruptured aneurysms. They mentioned that when early cisternal access was limited due to brain tightness, removing the anterior clinoid process allowed for early cerebrospinal fluid release. This reduces the need for aggressive brain retraction, which we all know is a major goal in subarachnoid hemorrhage cases.
But the procedure isn't without risk. The optic nerve is right there, traversing the optic canal just inferior-medial to the clinoid. The paper highlights several potential mechanisms of injury: direct trauma from instruments like microrongers, thermal damage from drilling, or traction during bone removal. They even mention the risk to the ophthalmic artery, which can lead to ischemic optic neuropathy.
And that's the gap in the literature they aim to fill. Most studies look at patients who already have visual deficits. This study looked at 16 adults who had no preoperative optic nerve compression or visual pathology. This was a clean slate to see the iatrogenic impact of the EAC itself.
Let's look at their methodology. It was a single-center study conducted between January 2023 and December 2024. They utilized a no-drill extradural technique. Post-operative assessments were done 6 to 12 months later, which is a good window to see stable structural changes. They didn't just look at Snell and visual acuity. They went deep into structural and electrophysiological data.
That's a key point for our residents listening. Snell and acuity is a crude measure, as the authors put it. You can have significant nerve damage and still maintain 20/20 vision. This study used automated perimetry for the Visual Field Index, or VFI, optical coherence tomography, OCT, to measure the retinal nerve fiber layer, RNFL, and visual evoked potentials to measure P100 latency.
Let's dive into those results. First, the functional outcomes. Visual acuity was preserved in all 16 patients. No one woke up blind or with significantly blurred vision. However, when they looked at the visual fields, the story changed slightly. 18.75% of patients, that's 3 out of 16, had changes. One patient had an inferior nasal quadrantenopia, and 2 had mild enlargement of the blind spot.
18.75% is not a negligible number, even if the patients were asymptomatic. It suggests that even with a no-drill technique, the manipulation required for EAC can have a functional impact. Was the VFI statistically different between the surgical side and the control side?
Actually, no. The VFI was statistically similar, with a p-value of 0.7. But those specific cases of field loss are clinical reminders that the nerve is sensitive. Now, if we look at the structural data, the OCT, global RNFL thickness was 95.8 microns in the ipsilateral eyes versus 99.2 microns in the contralateral eyes. Again, not a statistically significant difference, with a p-value of 0.230.
But they did find something interesting when they broke it down by quadrants, didn't they?
They did. They used a repeated measures ANOVA for the quadrant-based change in RNFL thickness. There was a trend toward greater thinning in the superior quadrant. While it didn't reach statistical significance after they applied corrections for multiple comparisons, that superior quadrant thinning is something to watch.
That makes anatomical sense. If you're unroofing the canal and removing the clinoid extradurally, you are working right over that superior and lateral aspect of the nerve. Any traction or microtrauma would likely manifest in those superior fibers.
And what about the electrophysiology, the P100 latency and the visual evoked potentials?
The results were remarkably stable there. The surgical side showed a mean latency of 114.8 milliseconds compared to 113.8 on the control side, a p-value of 0.223. So the conduction speed of the nerve remained intact. This suggests that the EAC, at least when done with this no-drill technique, doesn't cause significant demyelination or gross axonal delay in the majority of patients.
It's a reassuring study in many ways, but it also warrants caution. The authors emphasize that the possibility of iatrogenic visual loss must be considered, even in patients with no preoperative compression. They achieved their goal of improved exposure and proximal vascular control without any major EAC-related neurovascular complications, but those 18.75% with visual field changes are a sobering statistic.
Absolutely. For the residents listening, remember the anatomy mentioned here. The ophthalmic artery often arises near the clinoidal segment of the ICA. When you are performing an EAC to manage a paraclinoid or posterior communicating artery aneurysm, you are in a high-stakes neighborhood. The paper notes that this technique is particularly useful in basilar apex aneurysms and selected basilar apex cases as well.
One detail I found interesting was the no-drill aspect. Many surgeons use high-speed drills with continuous irrigation to prevent thermal damage. These authors used micro-rongers. Do you think that contributed to the lack of significant P100 latency changes?
It's possible. Thermal injury is a known culprit for nerve dysfunction. By removing the drill from the equation, you eliminate heat, but you potentially increase mechanical jostling or traction. The fact that the structural and electrophysiological markers were largely preserved suggests the no-drill method is a safe alternative, provided you are meticulous with the rongers.
To summarize for our listeners, in this cohort of 16 patients without preoperative compression, extradural anterior clinoidectomy was not associated with statistically significant optic nerve impairment across global RNFL thickness or VEP latencies. However, there was a trend toward superior RNFL thinning, and nearly a fifth of patients showed minor visual field changes.
It's a great baseline study. It tells us that EAC is a relatively safe tool for increasing surgical real estate and achieving early cisternal access in the setting of a tight, swollen brain. But it isn't a free procedure. It carries a small but measurable risk to the functional integrity of the optic nerve.
This study definitely sets a standard for using more than just Snellen charts to evaluate our surgical outcomes. OCT and VEP provide a much clearer picture of what's happening at the axonal level.
Well said, Alara. That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast.
See you next time.